A big hand for Peter Gasser.
Yes, thank you so much. Good evening, everybody. It's nice to be here and to speak in front of you and to see so many also young people which seem to be interested in that. And yes, then I just want to say something. It was difficult for me to come here. Yesterday I came by train and the train got stuck in Frankfurt because of the storm. So I went back home and I phoned to Michael and said maybe we can do it with Skype. And then he told no, that would be a pity. And then I arranged a flight for you. And so I came by Helsinki finally to Stockholm. And we had a nice day today together, so I'm full of impressions of Stockholm, and we had nice talks. I'm already quite enriched. And as he said, I'm coming from Switzerland, and I mainly want to speak about my work and the situation in Switzerland. And Michelle asked me not to bore you too much with historical facts, which you know or might know already. And so just one mentioning to the title, I gave it Psycholytic or Psychedelic Therapy in Switzerland. In German-speaking countries like Germany and Switzerland, we tend to speak of psycholytic therapy, which is mainly historical. It has to do that in the 60s mainly. There was a Professor Leuner in Germany who was treating people with lower doses of mind-altering drugs, but he had the treatment for a longer time, and he meant it to be a psychoanalytical treatment which embedded the substances. As in contrary, people like Stanislav Grof, they did not invent the term of psychedelic, but they meant mainly a few, 1 or 2 doses only of high-dosed mind-altering drugs, like 400 to 600 micrograms of LSD, and with the idea that will provoke a deep mystical or spiritual experience, which in itself is the healing agent of the therapy. Nowadays, I think the term psychedelic will be the term for the future, and there is a kind of mixture of this historical concept. So don't mind about psycholytic, maybe it will disappear. I want to speak, I want to introduce a little bit myself and the situation and the history in Switzerland. Then we will talk about psychotherapy in a psychotherapy environment. And then about psychedelic therapy in research, which is a bit different. And then I put in opposition psychotherapy versus research. What does it mean for therapists? And I mean, I stand here as a psychotherapist. I'm not a researcher, and I'm not an academic researcher, of course. I came to research just because I learned that this will be the way to apply the substances in therapy. Also in my office, it goes through research, but from my identity, I'm a therapist. And then at the end of my lecture, I will talk a little bit about the future, what I expect or what I hope that will happen in the next 10 years. Feel free to ask. There will be question and answers at the end of my lecture. Of course, there we have enough time for talking and discussing. But if you have questions during my lecture, just interrupt. There's no problem for me. Yeah, me personally, I am 57-year-old man. I'm married. I have 3 children. I live in a small town in Switzerland near Bern. You see just on the right side the pictures of of my everyday life, the nature and the little town I'm in. I'm in private practice as psychiatrist and psychotherapist. When I was 28 years old, I underwent my training in psychiatry. And at that time, there were 5 therapists in Switzerland who were allowed to treat with MDMA and LSD. And I went to one of these therapists, and there I had my first experience with MDMA and with LSD, which were really deep and important experiences for my life then, and I went into kind of therapy, learning therapy with that therapist, and even a training from 1989 to 1992. In 93, these exceptional permissions were finished, and no one in Switzerland as well was allowed to treat with MDMA and LSD any longer. In 1992, I joined a group of psychotherapists and medical doctors who are interested in that kind of treatment, and we have the name the Swiss Medical Society for Psycholytic Therapy, and this society still exists. We meet regularly, 2 or 3 times a year, and our goal is just to develop the method. Switzerland has a kind of history and tradition of therapy with mind-altering drugs. As you maybe or certainly know, LSD was discovered in 1943 by Albert Hofmann in Basel. And 3 years later, there was the first clinical study, which was done in the University Hospital in Zurich, done by Stoll, and about the medical potential of LSD. And the trial had 2 parts. The first was self-experience of healthy volunteers. That means that the clinical doctors on the ward in the university hospital, they went to work in the morning and they took 100 micrograms LSD, and they kept on working and were protocoling what they experienced. And then this was just put together to that study, which maybe without knowing about set and setting, we would say today that's not the best thing you can do, taking LSD and go to work. And on the other hand, the treatment was mainly with schizophrenic patients in the ward. And here it was the same. The LSD was just given to them as a medication. So they got it from the nurse in the ward and had the LSD, and then they looked how it works. And not surprisingly, it showed up that it doesn't help so much for patients with schizophrenia, which might be, I think that is true. I think that is not an indication for treatment of schizophrenic patients to give them LSD. We can discuss about this. And of course, it was also the case because of this, we would call it not appropriate setting to give it to them. This was not safe enough, so they just got it and they were somewhere in the ward. It was the first clinical study. Then a lot of studies followed. You know, LSD is one of the most developed and most well investigated substances, with several thousands of publications until 1970. 72, 73, then it stopped quite immediately after the ban of the substances. In Switzerland, it went on a little bit. There was a psychiatrist called, his name was Fassler, and he had an exceptional permission to treat patients with psilocybin. He was working in a hospital, and he gave the psilocybin to his private patients. There is little known about him, but because he never published and he was just a little bit a person on his own, so I do not know what he exactly did. And in 1989 he died. And then there was this famous time, in a way, 1988 to 1993 in Switzerland, with this exceptional permission, which we still are not knowing why these 5 therapists got this permission, which was a kind of carte blanche, we said. It's a free permission of treating with MDMA or LSD as on their will. They could do and treat whom they wanted, and they didn't have to report on the case. And they didn't do, and I mean, that's, in a way, it's a pity they didn't do research as well. It was then only me. In 94, 95, I tried to do a follow-up questionnaire with all these patients, and I also published this, but this was kind of minimum research on that field. We could have done much more. In 2004, a colleague and friend of mine, Peter Owen, did a MDMA PTSD study, which was sponsored by MAPS. MAPS, maybe you know, this American association who does this MDMA PTSD study, and Peter Owen did with 16 patients. He did this research in Switzerland. In 2007, I got approval for an LSD study, which in a way was followed the birthday conference for Albert Hofmann when he was 100 years old. And there was a conference in Basel with a lot of people coming there. And there we said it would be important to do some LSD research again, because LSD was just blocked over. Yes? Yes. PTSD is post-traumatic stress disorders. That's people who lived trauma, every kind of psychological trauma, which is a psychiatric or a disease or a disturbance which is difficult to treat with normal medication. So it's kind of hard to treat PTSD, and the idea was to have MDMA, to have a kind of treatment that is more successful than others, for example, antidepressant drugs. And after the conference in Basel, I tried to apply, and I was making a protocol and got finally the permission to do a pilot study with 12 patients in patients who suffer from anxiety due to life-threatening disease, mainly cancer. This study was finished in 2011, it's published, and it was then, I think, the opening door for that. In 2014, I got individual permission for treating patients outside of research studies. We call it restricted medical use. You call it also compassionate use. I will talk about this later on. And in 2017, this year in spring, we got a second permission for a second study, LSD, end of life and anxiety. I will show it. It's just after the pilot study. We do now a study with more patients to have statistically valuable results, hopefully, in the end of the study. First, I want to talk now about psychedelic therapy in a psychotherapy environment. So this is what I just called the compassionate use. As I said, this is a privilege for me, just as a therapist, to treat patients outside of a research framework. Those of you who did research, they know research is very restricted. It has to be operationalized. It has to be always the same. And in treatment, in psychotherapy treatment, I can react more individually on the needs of the patient, on the process he is in. The Swiss law basically is not different from the law in Sweden. So LSD, MDMA are Schedule 1 narcotic drugs. That means they are forbidden. And the law says on the highest level there is no medical use. And when there is no medical use, basically you cannot do anything. But then there is a second part in the Swiss law on the narcotic drugs that says the authorities can make exception to that law if there is a research purpose, if there is a development of drug purpose, or if there is a treatment purpose. So it's in a way contradictory, but I think the lawgiver wanted to open the door a little bit, and that's what we are now have a benefit of. So I got permission for now 15 patients, I think. And for research, we have a 3-step application for approval. We have to go to the ethics committee first in Switzerland, and when the ethics committee says yes, we have to go to the National Drug Regulation Authority, and if they say yes, we have to go to the Ministry of Public Health. And if all 3 authorities say yes, then you can do the project. And here for compassionate use, it's only the Ministry of Health who has to to give the green light for the treatment. So it's much easier. And I have to report, and every 6 months I have to do a reporting if everything is okay, if there is no danger in the treatment, and that's all. I can prolongate the permission for always on 6 months, and in addition until the therapy comes to an end, which I count normally is about 3 years and maybe 7 to 10 LSD or MDMA sessions. So that's the normal course of a therapy, I would say. The application for individual cases is not based or not centered on diagnosis. So the authorities do not say it's only for end-of-life anxiety, it's only for the study you have done. But they say they want to learn about what is the process that I'm following with the drug. So I have approval for different diagnoses, which is in a way an advantage. We can learn about not only about end-of-life anxiety with these compassionate use cases. I can learn about obsessive compulsive disorder. I can learn about cluster headache. I will tell you just later about this. And that's very important in a pre-research state. So that gives also an idea what could be a beneficial research for the next step when we see in compassionate use, yes, this is good for that patient, this is good for that situation, then we can think about where do we want to develop the method. On the picture you see the legal LSD, so this is in these vials, glass vials. It is dissolved in alcohol, and they drink it per mouth because it's, as you can imagine, it's not an easy procedure to put 100 micrograms in, where really 100 micrograms has to be in it in a kind of tablet or capsule or a vial. But it works very good, and I mean, I'm very happy that we have a legal source for LSD, because I cannot go onto the street and buy some street LSD for this treatment, as you can imagine. So some data about the patients I am treating in compassionate use. You see here I have 15 permissions of all kind of diagnosis, of different diagnoses. I started in 2014 with the first, and the last is just this year. I have 12 with LSD, 3 with MDMA, and yeah, some interesting things. Here, this is a long-time patient of mine. She is with me since, I do not dare to say, she comes in therapy since 20 years with me, and it's one of the most difficult and most touching therapies I've ever done. And although she suffers from PTSD, I thought that LSD would be more appropriate for her. And although she has that's contradictory in a way. She suffers from dissociation, and LSD is highly dissociative in his action. And nevertheless, she can learn about the mechanism of dissociation when she takes LSD, so that she learns about what happens when she goes away, when she does not feel present in the room. And LSD is just a helper or facilitator of learning about this coming and going in dissociation. And I think it was a good choice. It was also a good idea to treat her with LSD, because she really had a good development under this treatment. She's no more that terrified by this trauma. She had a severe sexual abuse by her father. And cluster headache, as you maybe know, this is a highly painful form of headache attacks, a form that is also called suicidal headache. As you maybe know, people are committing suicide because they really say, I cannot bear it anymore. And there are case reports on the internet that LSD and psilocybin helps sustainably. And so they come to me and call me if I could treat them for their headache problem. And I learned that this is maybe a use of LSD which is not like LSD being a catalyst for a psychotherapeutic process. That's the normal thing. That's my concept about LSD therapy. It's a catalyst, catalyzing an inner process of growth, of spiritual growth, of personal growth, of psychotherapeutic process, whatever you want. And here, LSD maybe is more like a medication. It's a kind of substance goes into the brain and helps correct anything. I don't know. So they are free of pain. They don't look. The people with cluster headache mainly don't look for psychotherapy. They look for a medication. And so I think my setting maybe is not appropriate for these cluster headache patients, but LSD hopefully is appropriate for the treatment of cluster headache. We have to construct another kind of setting, which is more about safety and helping the people just to go through that and then giving them food and water and whatever they need, but they don't want to do psychotherapy. Yes? I will tell you just in a few minutes. I will tell about my setting in detail. It comes. Yes, I now tend to find some kind of maybe neurologist or whoever who wants to treat cluster headache patients, because I think that would be a good use of LSD for people who are really, really, really suffering, Then I have a patient with obsessive compulsive disorder as a young man who has a time of 15 years of severe OCD with hospitalization and more than one, and he's in therapy, several therapies, and really nothing helped, unfortunately. And now he is in treatment with a behavioral therapist since 1 year, and she told him that maybe he could have a benefit from LSD therapy. So he does his behavioral therapy on one hand with that therapist, which is quite good, and on the other hand he comes to me and had these LSD sessions, which really helped him to integrate or to find out about the structure of the compulsive thinking. He said he learned now how it works, the compulsive thinking, and he learns to have, he then said, now I know I have a choice if I want to accept that I have to go under the shower for an hour, or if I can say 10 minutes is enough for being clean and washed. And that's for him very new to get a kind of a feeling of having a choice. And he did four LSD sessions, and he thinks that helped him most over the last 15 years, and that he is on the way to resolve the obsessive compulsive disorder. I think maybe he'll never will be just a joyful person doing everything he wants, but he has a better quality of life, we can say that, of course. And then another interesting thing is the question about autism. I have a patient suffering from high-functioning autism. He is a dentist, and my concept was when he takes LSD, maybe he learns about emotions. And unfortunately, this is not the case. I really have to admit with him, maybe it's different with other autistic patients. I have to say that maybe there's a kind of handicap. He is not able to integrate emotional processing. It seems to be a handicap. And then he has the MDMA experience, and something happens. And of course, I think our relationship improved. So he's quite motivated for the therapy, and he is positive to what he does. But there is no integration of the MDMA experience. And I think this is maybe a limitation of the substance. We cannot expect to treat everyone for everything. And Parkinson is interesting because there is a release of dopamine with LSD. So the patients who suffer from Parkinson's disease, they have an improvement of the Parkinson symptoms, but only for the duration of the action of the drug. So they can go to for example, they go to the toilet quite freely. They have no problem in walking, and they even can say, I felt like dancing, which I never felt for 10 years. But it is not a treatment of the Parkinson's disease, and it's important to be clear about that. We cannot cure, even it's not a cancer cure. I had to be clear in my study. We do not cure the cancer, but we can facilitate the dealing or the coping with the severe disease. And with Parkinson, it's the same. Yeah. Yes, of course. Worsening. With Parkinson, in general? No, I think, yeah, yes, you see, for example, this migraine patient, she came only once, and then she said she expected it to help for migraine. And it's a little bit like the cluster patient. So she was disappointed in the sense that it was not a cure for migraine. And I think what I learned with her is you have to be clear. It is a psychotherapeutic intervention. It is not a cure for, maybe with cluster it's a bit different, but it's not a cure for migraine. Although some people say, yeah, this helps and so. But I do not want give the impression of we are curing somatic disorders. She left after one session. I think I can say there are a few patients maybe who had no benefit, but there was no patient who deteriorated after that. And I mean, we do a careful selection in research, and also for compassionate use. I do a careful selection as a psychiatrist, and I would not take people into treatment who had psychotic episodes in their lives. In a way, it's too dangerous for me also, and maybe they would become psychotic after LSD treatment. That's not what we want. And I would not take people with severe personality disorders because they don't have stable relationship. Yes? No? This is the only page. Yes, now I asked him that maybe we could go on to LSD. And I applied now at the authorities for LSD and just explaining what's the reason why I want to change from MDMA to LSD. And they accepted. And now we have scheduled an LSD session for beginning of December, I think. And I'm just curious that maybe, because LSD is maybe helping him a little bit more to see about the structure, how he is structured in his autistic behavior, and not so much expecting the emotional experience. So I'm curious, and he is also curious. We will see. Yeah?
When you have a question, please repeat it.
Okay. Yes, I will try to remember. Yes? Yes, the question is if I should give regularly LSD to cluster headache patients. In fact, those who benefit from LSD, they have a kind of treatment schema. They take 3 times LSD within 10 days, 100 to 200 micrograms, and then when it's okay, then they have a relief. And when they feel that maybe the cluster comes back about 3, 6, 9, or 12 months, they repeat the LSD ingestion, maybe with lower dosage as well. But it could be that they have to do it every year 2 times or something like that, which is compared to what medication they take normally. It's an incredible relief. When you have to take LSD twice a year, then you are cured, aren't you? Yes? Aha, if the good effect is sustainable. Aha, no. No, the concept is not that the question is, on the remarks side, when I write good effect, if this is because of during the drug action or if it is a remark on the psychotherapeutic process. So I'm only interested in sustaining effects. So something having a good trip, he can have on a party as well. But having a good effect means a good therapeutic effect, which is sustaining after the drug action is over. Yeah, in the study, with how long does sustainable mean? So, as a therapist, I would say hopefully forever. For research purpose, we did a follow-up after 1 year, and I mean 1 year is a long time for research. And in that research setting, we saw that the reduction of anxiety was sustaining. So, and I think when it is sustaining 1 year, maybe it's sustaining 2 years. Hopefully. Okay? Good. Let me go ahead. Yes? The question is if there is a therapeutic value in combining LSD and MDMA. Yes, if you ask me as a therapist, I think I could imagine that it could be of value to combine the more confronting, the more demanding LSD with the more supporting MDMA in a way. But I would say at the moment we should not talk too much about combining these drugs, because on the research level you have all these questions of interactions and is this good, or does it cause problems, and you have to go to authorities and explain them why you should. I mean, they have difficulties to understand why we should give one drug to a patient, and it's much more difficult to tell them now we give them 2 drugs. So I think we are not at the phase of research and therapy to think about combining them, although it might be of some value. Good. Okay, let me take a little bit about holding a psychedelic session in psychotherapy. This is an important part of it, the preparation phase of the session. It is all about building of a trustful relationship. So it's building upon about trust. You might say, if you are a therapist yourself, I mean, that's the same like in every therapy. You have to build up trust. And in fact, to have a good relationship with the patient is the most important thing, I think, to have a good experience in the session situation. It is that what helps most, that you can make an intervention when it is difficult. So I put much emphasis on this. That doesn't mean that you have to know the patient for 10 years, but it means that the patient trusts you and you trust the patient. And when you feel that's okay, and the patient answers you in the same way that you can rely on, he is trusting you, then you can go into the session. So it is like in every therapy we learn about patient's history. We show empathy and interest. We are witnessing his history. And then I think that's a bit different maybe to other therapies. We are showing expertise. We are showing, look, I know about what you will experience. And there is a whole discussion. Does a therapist necessarily have to have this experience? Or is it enough when we know it by intellectual expertise? Or does he have to have the personal experience? It's not so easy to answer the question sufficiently or so, but I do believe that I have to know by myself what LSD is to guide and to support a patient taking LSD, because there are long phases of not talking. It is not a talking day mainly, and if it is silent, and I have to trust that I can imagine what happens now with him without asking him or her. And so, yes, we are explaining the setting, the substance. We answer the question about the dangers and the potential of the substance and all that stuff. And I think my attitude is really answering all questions, and all questions means all questions, until the patient is satisfied with information. And then that is a good moment to say, okay, now we can go on. And then the psychedelic session. As you see here, with compassionate use, I have chosen to do it in groups. And I have worked on that, and I could finally convince the authorities to do it in groups. When I had the compassionate use, the permission to do, then I asked them, would you allow it to do in groups? And they say, yeah, is that safe enough? Or why? What is your idea about it? And I told them, yes, look, I think a group experience is just an additional benefit for them, especially the integration phase. I will just talk about this. And so we were talking to and fro, and then they proposed to do it with 2 patients. And then I said, no, 2 patients, that's a couple therapy, that's not a group. And then they agreed to treat 3 patients, and I did it with 3. And then I reported them that it was fine and the people felt safe enough and all that. And now they agreed to do it in groups, which is for me the good setting for this kind of therapy. I will just explain it afterwards. Yeah, on the day of the psychedelic session, we worked out a kind of workshop. We do the psychedelic session in a 3 days workshop. So the first day we meet in the evening, and then we do a sharing in the group. People explain who they are, why they are in therapy, what's the problem, what's the intention they have, why they come here and all that. And so that the others learn who is with them for this session. I do some exercises, maybe a meditation with music, or body scan, or breathing exercise, just a kind of relaxing or regressive exercise to anticipate a little bit what happens the next day. And then they go home, they come back the next day in the morning at 9:30 or so. Then we are just asking about how they are, who they are, how they are, what they feel, if they had dreams, if they have to tell them something which is important. So we are just clearing the set. What is the inner state of the people? Are they ready for the session? And they, at any time, they can withdraw. They even can decide to remain the whole day without taking the drug. So they are not forced to take it. And if I would not feel sure, I would propose to someone and say, maybe it's not a good day today, and so on. So there is no urge or no necessity to take it all the time. The setting then is, we are a group of 8 to 12 patients. And I do it together with a friend, Peter Owen, who did the MDMA study. We do it together, he with his patients and I with mine. And we have a third therapist, a female therapist, so that we are the 3 of us with 8 to 12 patients. And then they take the substance, be it LSD or MDMA. So the during of action with MDMA is 4 to 6 hours, with LSD is 6 to 8 hours. So MDMA is shorter. It means that when the MDMA patients feel that it goes slowly to the end, they are just asked to stay calm and stay in a meditative state and to be in the room. And that works. These 2 substances together needs a little bit of discipline, that people really can stay in the room and be relaxed and listen to the music. But normally that this works without difficulties. Then at 4, 5, 6 o'clock, we do a kind of sharing round. People are telling 2 or 3 sentences, where they are, what they experienced just now. At 6 o'clock, we have some meal, light meal, and then they can stay for chill out or go home. Then we end the day, and the next day in the morning we do an integration round. I will tell you what we do then. And yes, I hope I could explain you a little bit what is the benefit of the group. I think every one of you who has done conventional group therapy, in group I learned that there is an additional thing that you cannot do in individual therapy, namely learning from each other, having contact to other people who have maybe the same difficulties, who have resolved or are stuck in the same kind of problem. And a group is a helping organism. And if we do it in groups, we can benefit from that. Although people have also to learn that it is a highly individual process as well. So it is not a group therapy from the beginning until the end. That the first part of the day when they take the drug is really the individual process, and they don't talk to each other and they don't go to each other. And so it is important. Everyone has to respect to be a part of the day on his own, and for his own benefit, on the benefit of others. And also when he goes to the toilet, he should not go like that to disturb these others, but be gentle and thinking about this. But in the second half of the day, and especially the next day, the group is really a helpful organism. Yeah, that's it. And I want to say something about what I think what a guide is, or some people say a facilitator, or a friend of mine, she says, we are a kind of midwife because we are helping to give birth to a personal process. I have a kind of three pictures or three imaginations I have what I think I am. On one hand, yes, I am the mountain guide because I know more about these processes than the patients. And at some points I can say, yes, look, please go back and lay down and try to relax and calm. That's better than speaking now. So I give kind of instructions, what is best, what I think it's best now. And to a certain extent, I have to do that to facilitate or to make the most benefit for the patients. But I am not the person, and that's important, I'm not the person who knows or who says, where does the trip go? I think the substance and the patient, they are the kind of pilots. They are having the process wherever it goes, and I'm just be with them. I'm not the guide and say, tomorrow you will learn about your early history as a child because your mother didn't treat you quite well in the early phase. Although this might be true, maybe it's kind of other thing. And I never know, it's unpredictable. I know an LSD session is unpredictable, so I'm really not the mountain guide. A lot of the time it's sitting together, or the patient is lying and me am sitting, or at some time also lying, but we are just quiet. The two of us, he is in a quiet in the process, I'm in a quiet process. I'm all time I'm aware that can be necessary to intervene. I'm there, but I'm not saying anything and not doing anything. And then at some times we are just like the cabin crew in the airplane and provide them with a blanket that they are warm, or looking for having something to drink, and just a kind of caring role, which is also important and appreciated by the patients. What are the interventions I am doing? I have a toolbox of interventions, as you see. I tell you something about music and silence just afterwards, but the therapeutic and caring attitude, it's not an intervention, but I think it's important for me, just what I said, what is the role I'm in? That had an impact on what the patient is experiencing. And then, because it is a highly, how do we call it? We are not speaking so much, so I'm not always asking, is that appropriate for you? What are you like me to do with you? And where are you now? What are you experiencing? It's nothing with that. It's basically not saying too much. And then I have also learned to follow my intuition. And intuition is nothing magic in my understanding. It's not about coming information from I don't know where, from the cosmic space. Intuition is a kind of experiences I have within me, and something shows up based on my experience, and then I apply it. That's what I am doing, what I mean by intuition. So it's based on knowledge, but it's intuitive in a way. I'm just trial and error situation. I try it, maybe it's wrong. When it's wrong, I withdraw. If it's appropriate, I follow it. About music, I tell you something just in a few minutes, seconds. Bodywork. Although I'm trained in bodywork, this is not a structured bodywork. I'm not doing exercises with the patients. Bodywork means mainly holding, giving a hold, giving a physical touch for making sure I'm here, you're here, I'm supporting without saying words. So that's the most important thing I understand with the bodywork. At some point, it can be maybe a hand on the head, or maybe on the chest, when I know it is not misunderstandable or so. But it's gentle body work, and it's mainly reassuring my presence and the patient's also presence, I would say. Talking in group therapy, we discourage to a certain extent that the people are talking, because it's disturbing for the others. In individual therapy, like in research or individual therapy, there is possible that they talk more, but the problem with talking is the inner processes are quite fast and talking is quite slow. So if they talk where they are, maybe they are just at another moment, in another situation. When they talk about the situation who was before, that can be confusing. And so I tell them, I mean, it's okay if they need to talk for reassuring, but I think we can talk tomorrow. Tell me tomorrow what you experienced. Now go into the experience and make it your own experience. I don't have to know it at the moment. So there is little talking. And then the real emergency interventions, they are more about just ending the process. We can interrupt LSD or MDMA session by giving benzodiazepines, for instance, or neuroleptics. But I never had to do that. I'm happy with that, because I do not want, if it's really possible, I do not want to interrupt a process who is maybe difficult or very difficult, but the bad trips turn out to be good trips when they are understood fully. That's what I experienced often. And I mean, psychotherapy is also about having difficult situations. That's in conventional therapy the case, and that's here also the case. So emergency interventions is really emergency when I don't know what, the patient would jump out of the window or so. Of course, then I would give some medication. But thank God I didn't have to do that until now. But it is possible. Yes, let me say something about music. Music is a kind of being able to communicate, being able to reach the patient, or being it in every layer of consciousness. You can reach someone with music, even when they are in a highly dissolved and spiritual and out-of-body experience. You can play music to get into contact with someone. And we have to, I have to apply music for that, for structuring and orientation of a process. So this is an important kind of intervention, playing music. And I had this diagram from a clinical study which was done in Basel with healthy volunteers by Matthias Liechti and Jasmin Schmidt, and she published about it. And they asked the volunteers at every hour, I think, what they said about the drug effect. And you see this typical kind of of effect. This is a placebo group. There is not so much, but when they take LSD, they have an increase, a kind of steep increase, then a plateau, and then a slow getting back to normal. You can say a landing phase. And in these 3 phases here, I play more calming, relaxing music, just to open up the space, going into the experience. I would play some meditation music, whatever. And then in the plateau phase, I would play more strong music, beautiful music, whatever beautiful might be, but can be from Pink Floyd over classical Western music to world music, whatever. But a kind of opening music. And then in the landing phase, I play more like singer-songwriter, good music and with text, and so for just coming back to normal everyday life. I have just copied you a playlist of music I played some 2 months ago, and it is just following these 3 phases in a way. I mean, it's just an example. I know you can talk about music. We talk in the medical society. This is an eternal topic. What I learned, and also the discussion of what is better, the music from the player or the live music of people playing archaic instruments like gong or drum or whatever. What I learned is, especially with groups, there is no right music or wrong music. Although there is music I would not play. I would not play yodel music or heavy metal music. Although for some people this is good music. I do not deny this. But I know even sacred music, for those who have no good experiences with the church, they would not like maybe a mass of Mozart or Bach. And I'm a bit, I do not want to provoke bad feelings in patients. But if you play even this music, some people will say, it was fantastic. Oh, it was so aesthetically convincing and so beautiful. And others will say, it sounded like metal noises or so. And the important thing is not to find a music which is appropriate for everybody, but to think, yes, that's interesting. Let me take about it. Why is it beautiful? I mean, maybe they cannot explain, but to some extent, why is it so terrible for you? Then you go into personal history often. Yes, you have a question? Sorry? Yes, the question is music with lyrics. In the third part, I would also maybe sometime read a poem to give some impulses of thinking about topics. And if you play a love song in the third phase, especially with MDMA patients, they will just have some experience with love topics. And I think in this third phase, maybe that helps to structure a little bit the experience. And but I don't want to overload them with text, with lyrics, and also they should not be too much into other person's thoughts and so. So I play it to a certain extent, but not too much. So not every song will have a good text to show them some aspects of human life. More up there? Uh-huh. Yes. So the second question is, I didn't get the first question. The second question was, what is the psychology behind that some music is pleasant for some people or some music is bad for some people? What is in this framework? That's the second question. What was the first? Okay. The first question is if people have questions before entering the experience. It's the same like in therapy and preparation. I try really to give a response to every question there is so that people really can feel free from unanswered questions. Aha. I mean, a common question is what are the side effects and dangers of the therapy, and is there a risk for me to do that, and what if it doesn't help? And then I try really to explain what the dangers are. Another common question is, do I have to read something or to prepare in a special way? And then I say, no, there are no dietary restrictions they have to follow. Although they should not drink too much alcohol the day before and not smoke cannabis. That's my recommendation. And they don't have to read or prepare in a special way. It is sufficient just to enter the exercise, the experience. These are examples. Then the second, I have no psychology about aesthetic of music, but I think there is no universal understanding of music. There is really a kind of the tradition of hearing, the preferences. I mean, why are some people are in jazz and other are in classical music? I mean, I don't know. That's normal. We are different human beings, and maybe I don't know if there is a psychological explanation for that. Maybe not. Maybe it's like with the food. Not every person is eating the same things. So I think there is a variation, and I accept the variation. I have not the idea. I have to find the music that really is appropriate for everyone at any time. So that is it. Yes? Of going outside? Yes. So the question is if there would be a benefit of going outside into nature. I think you. The question is if there is a benefit to go into nature. Yes. Yes, I think, of course. I mean, all people who ever have taken these substances, most of them say it is fantastic to be in nature. It's fantastic to see the sun, the stars, to hear the birds, to see the plants, and to have deep encounters with our nature, in experiencing the nature outside. I admit that would be very good, but for safety and security reasons, I cannot do that. My office is in the middle of the town, and if I go outside, we first have to go 500 meters until we are in nature, and these 500 meters are crucial because then you have so many influences by traffic, by other people. They are so busy, then they feel maybe a lot of insecurity on the way to go there. But if I would have my office on the top of a mountain or on a hillside or in the forest, of course I would go out. Yes.
So we all love questions so much that we would like to save them till last. Unless there is something that you do not understand about the current slide, I would please advise you to save the question till last. We will have plenty of time for a Q&A.
Good. Okay, I was too inviting, obviously, for having questions. Yeah, a little bit about silence. I would say 1/3 of the time I spend with the people is with music, and 2/3 is silence. And the silence is an important part as well. It helps in a way to go into the personal process, because music always is an influence from outside, which can be a help for going into personal process, but it can also take the attention outward. And so the silence is welcome to go back in the inner realms and in the inner process. It is also, I don't have the concept of sensory overload. I mean, you can play all the time music and people come into an overload, which makes them let go deeper and then just let go the music through. That's what happens when they go to parties. Also, there is all the time music, and that works also. But it is not my psychotherapeutic concept to help people go into the process by overloading them with music. So music has not that function. And then for me, the silence is more what they experience in meditation, for example. It's also meditating, feeling the breath going inside. It is quite the same here. The problem with silence can also be that is too much for people. They can dissociate or fragment. They can be lost in the silence, because silence can be very powerful, and then they will need some music. So I play music. There is not more than half an hour of no music normally, because we don't have a total fragmentation, which is not helpful. The finishing of and releasing of the patients, as I said, at about 6 o'clock in the afternoon, we eat together, fruit and bread and cheese, whatever, drink some tea, and this light dinner helps to look how integrated the patients are already. If they can leave the situation, if not, they can stay there for chill out. Chill out means there is no more guidance from the therapist, but they can stay there, listen to music, and just being calm and waiting the rest of the time for the experience. And then when they are about to leave at 7 o'clock or at 10 o'clock in the night, they can go. If not, I mean, they could stay overnight, and we would care about them, which normally is not necessary that somebody has to stay overnight. I mean, this experience is just an experience of dissolving the normal personal structure and of regaining the personal structure. Is about opening and closing, and the finishing is also about closing. It's not necessary, and it's not wishful that people open up with LSD and they remain open all their lives, because when we go to the bank, or when we need to go to the train station, we need an ego structure that helps us to orientate. And to a certain extent, we have to finish and to close a little bit the openness. It's not only, I mean, the action of the drug makes it by itself, because at some point the drug action is over and then it's closing by itself. But it's also a conscious process and a question: how much closeness do I need for everyday life, and do I want? And so we can help this making also a conscious process in that phase here. The next day, we meet again at 9:30 or so, and then everyone tells about the experience of yesterday. So they have, 15 minutes of time, and they give feedback to each other. They explain it, and this is an important part of the integration of such a process, just to tell to others, and at the same time, they tell it themselves also, because it's the first time that they try to find words for maybe ineffable things they experience. It's difficult sometimes to explain what it was about, to find words for that. And this is an important intervention here, to try to give words to this experience. And then what I say about the group, sharing the pain can be a very healing experience, because you share the pain to people who are open for that, who have maybe the same pain, who know that it belongs to human existence to experience things like that, and also to learn from others. Maybe they say something, you say, "Oh yes, that's very important. I was wondering, I was asking the same questions for me, giving feedback. So that is the group process, and then at 12 o'clock or so, people are released, going home. And then it's about integration. I think integration is that what is the difference between going to a party or a festival and having good experience. And I'm absolutely sure that people have important experience when they go to party and festivals. There is no doubt about this, and maybe experiences for their lives. But in therapy, we want something else. We want a kind of conscious integration of such a session. And I think I have mentioned here 7 points, and they are in chronological order. So the first intervention of integration, of making this experience a part of my own life, is a sharing round during the session at the end, maybe at 4 or 5 o'clock, which is people, some of them, they can say only 1 or 2 words or 1 or 2 sentences. Others can just talk a little more free. That's not important what they say. It's more important just to focus a little bit. How am I now, and what is my inner process? Then, as I said, the dinner is a next step. And then the chill out, even if they go home, often they say yes. When I was home after the dinner, then I lay on my bed, and the things that I had, the pictures of the day and the experiences coming back. So often they relive what they experienced before. Then is the sharing, as I told you. And then they write a protocol out of the memory. They write down what they experienced in 1 or 2 pages or so. And they bring it to the therapy, and I can read that also, and we are discussing it with the protocol. In the individual therapy sessions, we try to understand and to give the experience a meaning. And so at the end, there should be, that's the last step of integration, the growing consciousness in daily life. That's what we expect to have with that kind of treatment. And then the ending of the therapy is in a way a difficult part of the therapy, because a lot of patients have the wish to do that the whole life 2 times a year. Why not? I mean, why not coming every year 2 times to the therapist and doing a workshop of 3 days, a kind of personal growth experience? And I'm sorry then to say, no, it is therapy, and therapy has a beginning and the end, and we must find the end, although maybe you could be convinced that could help you the whole life. And what is the right moment? And I have here 2 quotes. One is a patient, she is with me. She is a woman with multiple sclerosis, and she said, slowly I start sensing the nature of LSD a tiny little bit, a giant multi-intelligent something that acts somehow on different layers of consciousness and finally leaves golden fertile soil. And I think that's a nice picture, isn't it? And to have fertile soil means also you can end therapy because the soul will remain fertile, so you can do it. And then what Sidney Cohen, he was an American psychiatrist, a close friend to Aldous and Laura Huxley. He was the one who gave Aldous Huxley the LSD when he was about to die. And he said, what's here? I don't think I have to read it. You are more quick in reading in English than I am in saying it. But it's important what he say. It's important what he says. And I think, yeah, the therapy does not go until enlightenment. It's not about being a perfect person. It's just coming into a growing and learning attitude towards the own life. And then I think we have to end therapy. Let me say a few things about possible mechanisms of change. This is I would say a 10-year slide. Because it is not scientific, it is out of my personal experience and reflecting on what is what is the change mechanism of psychedelic experience. So on top is connectedness, and maybe when you know the research of Robin Carhart Harris and his team, which was quite published also in the media. What he shows is when you take LSD or other drugs, there is more connection between networks in the brain. They are just more connected together. And in a way, this is also a picture for what we experience. I mean, if you ever have taken LSD and you look at these pictures from Robin Carhart Harris, you say, yes, it's obvious. That's what I experienced. That in my brain, there is so much connection. For example, maybe people say they listen to music and they see optical, visual phenomena. So music, hearing and looking is more connected together, and feeling and thinking is more connected. That's what we wish for in therapy, that these things are more connected. And I think it's a good way of explanation. People feel more connected with themselves and with socially more connected, and with the environment, with the world more connected, maybe even spiritually more connected. So I think it's a useful way of explaining the benefit of when taking these drugs. The second point is maybe basically the same, a more holistic way of perception, emotion and thinking of known and unknown inner and outer realms. I think it's a kind of experiencing more holistically our world. And then of course the spiritual or mystical or experience can be, the peak experience can be something that helps by itself, like in psychedelic therapy, what I say in the introduction. And biographic regression and understanding is one part, that is the more psychotherapeutic part. And then maybe you know the work of Grave. He's a German researcher for psychotherapy. He tried to figure out what is common to all psychotherapy methods, what are the common factors that help. And he figured out these 5 points, and mainly the first 3, I would say, they apply perfectly also for psychedelic therapy. So it's not outside the psychotherapy model what we are doing. And the relaxation, I was just, it's not only a physiological relaxation of muscles, it's more psychologically, which makes the people more open. And the point of challenging the fear is maybe a kind of behavioral, in the behavioral model, you challenge the fear to overcome it. And of course, if people take LSD the first time in their lives, they will have a fear, they go through, and in the end they say, yes, it was a good experience. Just a little anecdote about the therapeutic process and about projection. This is a patient who wrote that in the protocol. And the last sentence he said, he looks through, he understands mankind, he means me. And I want to say something about that. I mean, that's nice when a patient says something like that, and he's an intelligent person, we can discuss it. Of course, I'm not looking through, I'm not understanding mankind in the total, that's clear for me. But I think people taking these substances, they tend to idealize the therapists more than in other therapies. And I think this is one of the biggest danger we have to deal with. It's more like people can become psychotic with LSD. Okay, yeah, that's a risk, of course. They can have troubles. Yes, that's a risk, of course. But I think that the biggest danger is to go into ego inflation thing when you are the therapist, and people, they are really grateful, and they say, oh, it was a good experience, and you are the provider for that, you are the facilitator for that. And although this is true, we are not superhuman. We are just doing a good job, like we do in other jobs as well. But here, this kind of idealization, I think we really have to be aware of. And when this therapy will more commonly used, I think that is one, we have to point on that and do supervision and intervention and speak about this danger. Otherwise, we will have a kind of trouble with people really nurturing themselves as therapists in this kind of narcissistic way. So that's what I want to say with that anecdote. Maybe there is not enough time. I wanted to read you a text out of a protocol, but I think you would like to? Thank you. So I was telling you about this woman. She's in therapy with me since a long time. She was severely sexually abused by the father when she was a child. And then she had 200 micrograms LSD in December 2015. And she was writing in the protocol, I just read it for you. I feel fear. Again, I'm pacing back and forth, standing edgy in the room. Peter, the room is dividing. Indeed, out of the one therapy room, there are coming out multiple equally looking rooms. Full of fear, I go from room to room, and every time I meet you, Peter. But which of those is the real one? I am sitting on the sofa, but my agitated body is not able to sit quietly. It drives me to walk around. Where are you, Peter? 1 minute later, I'm revolving, fidgety on the mat. You give me your hand. Are you the real Peter? Yes. I try to calm my nervous, hyperventilating breaths, but it is out of control. There is music. I'd like to dive into it, being carried and guided, but it seems to be so unreachably far. Am I fallen between two worlds? Do I become psychotic? Full of panic, I'm jumping on my feet, walking monotonously from one corner of the room to the other, from one room to the other. I cannot support that any longer. In addition, I see in your eyes, Peter, that my restless state is difficult to support for you as well. I feel deep concern for you, but suddenly in all that sorrow and fear, a deep and confident knowledge shows up. It soothes my sorrow in giving me assurance that you are able to look after yourself and that you will be prepared to go through that with me. Soaked with sweat and exhausted, I lay in the middle of the room. What happened with me? I start moving very slowly. I feel the floor and the soft carpet below me. Did I return to the world? A calm and comfortable warmth flows through my hectic body and leaves a big rest in it. My toes go over your foot, Peter, and now I'm sure that you are the real one. This situation lasted, I would say, half an hour, maybe 3/4 of an hour. And I really can tell you, 3/4 of an hour can be a long time if you don't know how it is going on. And I felt that she was lost. I was not so clear about what she was writing, but she was so in panic and she was so restless. And just to be with her and to try to give her a support and just to wait until this kind of panic will be over. It was just hard for the two of us. And she is right when she said that she saw deep concern in my eyes. And I mean, you must be honest about that. You cannot say, no, everything is okay. When it's not okay, it's not okay. So there is no possibility to hide, because when people are so open, they feel also me. And it's not that I have to be honest in the way and say, oh, I'm full of panic and I have to call the police because I don't know what to do. But you have to be honest and allow the patient to see the concern in myself. And just to bear this and to give hold and play a little bit of music with the hope maybe that helps. It didn't help so much what she says, but then finally she felt the physical contact and she She came back to normal, and this was individual therapy. This was not group therapy. When I was starting in 2015, I did it individually. And it turned out to be an important experience for her, and it even deepened the trust between the two of us, because it is a kind of, she could do it, and she was strong enough to bear it. So it was challenging, but it was a good experience finally for her. And yeah, but this one I will jump. And then that was the part of psychotherapy, psychedelic therapy and psychotherapy. And now I want to tell you something about psychedelic therapy and research, what I have done also in 2 projects now in Switzerland. And first, this is all individual setting. There is no group setting because of methodology. We didn't dare to propose that to the drug registration agency, that we want to do some drug research in groups. That we thought, no, at the moment we should not do that. So it's individual. But this has also advantages. I mean, it's very demanding, and it's with one person over 10, 12 hours to be in one room is challenging. And even when it's placebo, it's more challenging, as you can imagine. And both is not so easy. But for the patient, is a clear and exclusive contact. I mean, there is no similar situation in psychotherapy that you have a therapist for 10 hours for you, and he is really caring with you and does everything that you are in a good shape, in a good process. And I am there all the time. I only go to the toilet. I'm in the room with the patients. I do not read, I do not write, I do not play with my smartphone, I do not eat unless the patient is eating. So I'm really aware in the room, prepared to react, and that's it. That's all I do. I play the music, and that's my main work I have to do. And in 2007, the first LSD studies we did with 2 therapists, a male and a female, which has some advantages. But now in 2017, we do it only with 1 therapist, also because of costs. It's very expensive to have 2 therapists for a whole day experience. That raises the costs of a study project. And I think, I mean, normal therapy also works with 1 patient, with 1 therapist. It's not necessary really to have 2, although it has some advantages. And as I said to your question, it's indoor. We don't leave the room. We don't leave the office. So this is the first study 10 years ago. It was a pilot study, and we did it like the golden standard for drug research. It is a randomized controlled trial, and we were said this is the only chance to have application for a research project, to do a randomized trial. That's what we did, although, as you can imagine, the unblinding is 100%. After 1 hour, the therapist and the patient, they know if they have placebo or LSD. So you cannot avoid that. Here we gave 20 micrograms of LSD as an active placebo. So it's a sub-threshold dose. The full dose was 200 micrograms. The placebo was 10% of that. But even with that, we had 100% unblinding. That's a methodological problem. You have to discuss it, and nevertheless, we do it at this moment, we do it like drug research. In fact, for me as a therapist, it is psychotherapy research, because the drug is a facilitator of the therapy, as I told you. It is published in these 2 papers. One is the quantitative results, and one is the more qualitative of interviews we did. These are the 2 publications we did. Here, the timetable, you see people had 2 LSD sessions after 3 weeks and after 6 weeks. And in between, they had conventional psychotherapy. So it is a kind of LSD experience embedded in a preparation integration phase. So this is the core of the treatment, and this is the more scientific part of it, and the questionnaires they had to do. People came. There are some interesting things to see. You see, the people are in the second half of the life, which is not surprising. Cancer and all these severe diseases are mainly in the second half of the life occurring, and most of them never had LSD before. Only one had LSD, one had psilocybin, and one had MDMA. So they are mainly drug naive. Which is interesting to see how they react if they take LSD the first time. And here you see the life-threatening diseases. It was mainly carcinoma, cancer patients, but some of them, it was also one with Parkinson's disease, one with Bechterev's disease, which are also conditions where patients have to face the possibility of a near death, that the death is not when you are 90 or 100 years old, but maybe in 1 year or 5 years or 10 years. This is important. We were measuring the states of consciousness with this states of consciousness questionnaire, otherwise called peak experience questionnaire. I mean, only 2 or 3 things. There are 6 dimensions of states of consciousness we were measuring, but the important thing is to see the placebo condition, of course, is less showing effect than the full dose condition, so that's not surprising, but you see it. And then you see that the most they mentioned is a deeply felt positive mood, so that was the most important. The bad experiences, here called nadir experience, there is not so a big difference between placebo and full dose. And like peak experience, that's just the summary of all those. So here is much more difference between the beneficial effects than between the bad drug effects. We were measuring anxiety. That was the main measurement tool, was the Spielberger State and Tried Anxiety Inventory. And here you see just the state anxiety was diminishing with full dose condition, and also the trait, which is important. The traits is more the personality traits of anxiety. Also, that seemed to improve after 2 sessions of LSD, 2 months, and then even after 1 year, that's what I was telling you, seems to be end of the study, and then we did a follow-up 12 months later, and the anxiety levels remain quite the same after 12 months for state and for tried anxiety. That's not so an interesting slide. People had to mention so we just measured all the side effects they mentioned by themselves, and we counted it. So most side effects are chills, feeling cold, and unsteadiness. When they stood up and went to the toilet, they felt a bit shaky, and dilated pupils, sweating. Anxiety also for colleagues. So the side effects are moderate, are mild. There we had not to face difficult side effects. And then after this pilot study, we just plan now for a second. No, we don't plan. We are making it. We have a second study now for the next 4 years until 2021 with 40 participants, which is enough for statistical evaluation. It's quite the same as before. It's this time not only with cancer patients, but with psychiatric anxiety disorders as well. And we have this time a crossover design. So every patient gets LSD and placebo in random order, so that we can compare the groups, and we can compare within the subject also. So we think that's quite a smart methodology, I think. The timetable is basically the same like in the first study. We have 2 treatment phases of, this time a little bit longer, half a year about, and they get 2 LSD or placebo, and half a year later placebo or LSD, just in the random order. And this is also in a psychotherapy process integrated. So it's basically the same idea about it. If I want to tell you something about what are the differences between psychotherapy and research, because I think there are some basic differences. So if we do psychotherapy, we have time. We have a long process which is open-end. It goes until the patient and the therapist have the idea that it could end. As well as in research, it's short, it's timely limited, it's structured, it's always the same. The training of the therapist is different also. Here it is more comprehensive, you have to be a kind of psychotherapeutic training. Here mainly it's more maybe manualized. We take some people, they are doing these kind of treatments, and that's all they have to do. And also the relationship is different, I think, and you have to be aware. In psychotherapy, we have time to build up a therapeutic alliance, as well in research. We are more the experts introducing the method and telling them, now you have to do this and this and this, and then we will meet and we will make the session. So it's more, you act as an expert, not so much as a therapist, which is different, which I think that's not a problem. It's not one is good and the other is bad. We have to take in account that when I'm the expert, I'm explaining much more. It's not about an evolving process. And the treatment setting is here it's much more individual, and here it's restricted. You have to follow the protocol. Then the setting of the LSD session, here it's individual. I do it in my office. I do it the way I am. In research, sometimes it's more in scientific because it's in a hospital. Although what I saw, like people in Baltimore or so, they tried to make a comfortable room that people could feel in an agreeable surrounding. That's in a way again the same. That you have another task to fulfill when you do science research, or if you do psychotherapy. And I think about that in therapy. There is a whole transference which is evolving, it is developing, and in a scientific study, you're just the expert. At the end, both should have, the participant in the scientific study should have a safe relationship, and here is the relationship is maybe more in process, can change over the time. It's not static, it's more dynamic. Preparation phase, I don't say something about that now. And let me take a few moments for speaking about the future, and hopefully also the future in Sweden. I think we are maybe in Switzerland some steps before you, but basically it's always the same if this method is evolving. So I was listing here my wishes and fears for the next 10 years. So if I come here, I think it is necessary that the psychedelic drugs are no more on the highest level of scheduled drugs. They should not be any longer drugs with no medical use. There is no use for that. That's a historical error. It was made in 1967 until 1971 under the impression of the hippie and anti-Vietnam War movement, and unfortunately also the medical use and the research use was put under the prohibition, and not only this social problem. And there was no reason at all to make it forbidden to use LSD in medicine or in research. And I mean, the error is that on rave parties and so you can get LSD quite easily, but for research and medical use you cannot get it so easily. So it's not only an error, it turned out to be the contrary of what was intended. And we should have a training, of course, for young psychotherapists who want to, or researchers who want to work with that. We should do more research in more countries, all these drugs, not only LSD, which starts now. We have a few countries doing that. Great Britain, the United States. Maybe there will be a psilocybin study now over several countries in Europe, Finland, Germany, and that should start. And then outside of research, only the possibility of therapy, like compassionate use. We go on with public education. I just gave an interview to one of your newspapers here. Hopefully they will write something, and hopefully they will inform the public about the benefits and the risks of these substances. There is no need just to say that it's only a good thing or whatever, but to give information so that the public opinion can be, yes, there could be some value of that. I would say that's the most important thing in public education, just to change the opinion in the public. We should have growing networks. What you do here, you are already a network. And maybe some of the drugs will become prescribable drugs, like what they try with MDMA, that MDMA is a drug, a registered drug you can prescribe and get. I don't think that will be for LSD in the next 10 years, because there's a long way to go to register a drug. My fears are that it could be a backlash with severe incidents when there will be some death or severe things that could cause a backlash. So it's important that we do a cautious and responsible work all the time. What happens when big money comes in? The pharmaceutical industry is lacking of good ideas. They don't have psychopharmacology drugs in the pipeline, so they're empty. And of course, if they feel or are convinced that they can make money out of psychedelic therapy, they will enter the field. What happens then? That changes the dynamics and will be difficult. I mean, maybe we cannot change that, but we have to be prepared how to react. What will be the changes when money comes to a great extent? And one of the fears also that we have a fragmentation, those who think they have the right method against the others who are the wrong ones and all that. I hope that the scene remains together and working on that development of different drugs maybe for different purposes, but basically the same, working in psychotherapy, personal growth, and all that. And now this is the end of my presentation. And maybe you know, next year, 19th of April, will be 75 years of the discovery of LSD. And in Switzerland, we plan a scientific conference. And I hope also in Sweden, you will have a kind of memory and celebration of that day. Let's see. Thank you so much. And thank you. Okay.
Yes, thank you very much, Peter. And as you say you don't want to have patients with questions unasked. So I imagine that goes with auditorium as well.
Yes. Yeah.
And we have some online. When? Online form. Is it on? Yeah. Okay. So questions in here. Would you kindly step here into form a line? And also, if you want to move around during, I advise you that. So form a line here. for questions. Yes.
I think sometimes people who have experienced this drug before in a recreational environment, for them to a certain extent it's harder to enter the psychotherapy way because they have to learn quite a different approach. For example, if they are used to take these drugs and dance all the time, and now they come here and they have to lie down the whole day and being very quiet. So they have to enter and to accept that you can take it in another setting. So they have to learn about the setting and that the setting makes sense for the therapeutic process. So in general, I would not say that it is of help that if they have experienced it before, but I mean, it makes it not impossible in a way. We have to discuss this and say, yo, look, you have an experience, but I do it another way, and it makes sense because of that and that. And if he agrees and is willing to enter my setting, then it's okay.
Just before we move to the next question, I wanted to encourage you to ask your questions online. You can do that by following this link.
We did not measure if 20 micrograms has a kind of microdosing, long-lasting effect, but it has some acute effect. It was some people said it was about 5 or 10 minutes of like LSD-like action. For instance, I had a poster in my office. There was a window, and you looked through that window, and then one of the patients said, "I had the impression." It became three-dimensional, and I really was into that three-dimensional looking out of that window for a certain time. But then after 10 minutes, it was over. And also this patient said, yeah, it must have been placebo because it was so short. Yes, there is a long discussion about neurotoxicity with MDMA, and then there was a whole time in the 1990s where it was propagated to be neurotoxic on false scientific results. Maybe you know that. This was a researcher, Ricordi. He was taking finally MDA and taking it for MDMA. This was cleared up. What we can say today for these therapeutic use of MDMA, that means taking maybe 8 lifetime doses of MDMA, 125 milligrams, is not neurotoxic. We can say that's safe. There is a research on heavy users, and even those who had 300 lifetime doses of MDMA, it's not really clear if they have cognitive deficits. And I mean, 300 times is a lot. I would not recommend to anyone to take 300 times. I don't think it's necessary to take it 300 times in a lifetime. But for our research or therapeutic approach, it is safe. So what we know today that LSD is a not toxic substance, and I'm really quite sure that you can take LSD all your life long, as Albert Hoffman showed us, by the way. And I think the problem is, inside therapy, we have to do it in a limited way, because we cannot go and say, oh, we have a fantastic therapy, but it goes all life long because it's so good that people want to come all their lives. That's not a good approach. I think we should say we do psychotherapy, it goes 3 years, it's so, and they take it 5 times, and then they will feel a benefit. But I think that the problem is that when they do some spiritual or personal growth experiences, they would like to do it longer. But at the moment now, I think we have to argue from the therapeutic view. I think from the toxicological or psychotoxic view, there is no way of thinking that could harm them if they take it 2 times 50 years or so. I think that works, but not in therapy. Yes, as I said, one is the psychosis. So if people have a schizophrenia, a psychotic experiences, or a bipolar disorder, we exclude them from the study. I would exclude them from compassionate use as well. And severe personality disorder is, in my opinion, is also a contraindication, like borderline personality disorder. With antisocial, I have no experience, but I would say it's the same. So those who are not able to build up a trustful long-term relationship. LSD has is no problem with any. I mean, I had last year, I didn't tell about that. I know of a 90-year-old woman who took LSD the first time in their life because she has a bronchus carcinoma. She was about to die, and she had the wish to take it. And she was taking with her son, who is a medical doctor, and he told me. So even old people can safely take LSD because it makes it's not a charge for the cardiovascular system. So it's mainly a slight elevation of blood pressure and heart rate, but it's the same when you go up the stairs, so it's not a problem. With MDMA and psilocybin, you have to pay more attention on cardiovascular problems. So I think people who really have blood pressure, which is a high blood pressure that is not controllable well, I would maybe not give psilocybin or MDMA, but LSD you can give. So yes, that's a good question. So I was just talking about this autist patient I have, the dentist, and for it is too difficult to be in a group, and I have respect for that. He says he's really not able to deal with so many people at one time, and I think he needs to, maybe forever, maybe to a certain extent, the individual therapy setting. And I have also a patient, she had a severe sexual abuse. She was raped in a hospital when she was underwent surgery. And for her, she needs to build up more safety first. And I didn't want to treat her even only myself. I had a female colleague, so we were the 3 of us, the patient. And I think she needs to go through a phase in the individual setting just to be safe enough. But then I think she will come to the group. And so if people if people really do not want to come to the group, I have respect for that. And then I think there are some conditions we have to be cautious and to prepare something for its group therapy, like is not for everyone. You are true. You are right. Mm-hmm. My concept is that psychosis is a loss of reality. A psychotic person cannot consider the layers of reality, and she does have the orientation of everyday normal reality. So she's not so well rooted in this kind of ordinary consciousness state. And if these persons take LSD, it is more of the same. So they make a deep and profound experiencing of losing the reality, what they do normally when they are in psychotic states. So for some of them, it's more of the same, it's destabilizing, and they will not benefit from it. But there might be a small group, because the LSD experience is not the same like a psychosis. It is, when you take LSD, you know it is a drug action. It lasts for 8 hours. After 8 hours, I come back to everyday life. And for a small group of psychotics, I think that could be of help also, because they learn to come back, how it feels like coming back into normal reality. So I think there might be a group who could have a benefit from LSD, but I don't know the criteria to separate those who will have a difficult destabilizing experience and who maybe not. And at the moment now, I am careful and I say I don't take any of them. Yeah.
Okay, 2 more questions here and then online questions.
So in compassionate use, I have a permission for giving 200 micrograms, but I can give less if I want. So, I mean, what we learned here also with the patient, for her, maybe 100 micrograms is the better dosage for her. And ever since she has taken all the other experiences she has made, she did with 100 micrograms. And I think she can handle that, and that's better for the process. And I think 200, that was too high. She overcame it, and so, but now she takes 100. And with MDMA, we had a standard dosage of 125 milligrams. There is more like standard. That makes not use to give more. It's not better if you have more, and giving less. Maybe 100 would also be possible. With LSD, we have more range, but I do not give more than 200 until now, because I've not so much experience about high dosage, and I'm not so much in that psychedelic paradigm. You blow out your mind totally. So 200 is for me in this, also in the group context, is the high dose. Because 200, I think there is a difference from 100 to 200. 200 really makes an ego dissolution to some extent. With 100 micrograms, people can remain in the awareness of themselves and be more stable. There in between is you step over a limit. I think even those, if you speak of patients having, for example, depression, when they take LSD, they should take it in psychotherapy in a setting which is guided and controlled. And if they have to do it twice a year for a lifetime, they should do it in therapy. That's one thing. For those with the cluster, if they take only 50 micrograms, I think they can do it at home. Because 50 micrograms, you can do a phone call and all that. It's not necessary to be in a controlled setting. And if it will show up that even microdosing is effective for, let's say, depression, that 20 micrograms is a good dosage, taking every week one dose of 20 micrograms, for that you don't see the psychotherapist. You can take that at home. I mean, you can brush your teeth with 20 micrograms. That's no problem. But it's a question of dosage and a question of, should it be a psychotherapeutic process or is it the administration of a medication? So if it's only the administration of a medication, you can do it at home. So my concept is not a way this diagnose-centered, which substance is better for what diagnosis. I think, I believe that with all of these substances you can do valuable, good psychotherapy. And I'm developing the LSD psychotherapy. I have experiences with that, and I can say where I make the experience of helping people in their diagnosis. If other people do that with ayahuasca or mescaline or psilocybin, that's fine with me, and we should not say this is the best or this is better for only... Yeah, maybe we can say maybe if ayahuasca will be better for psychosomatic conditions than LSD, which might be possible. Then with psychosomatic conditions, we should rather use ayahuasca. But this differentiation between substances has never been done, because we are all people convinced of our method and bringing our knowledge together at the moment, and comparing is for later, I think.
Yeah, thank you. Okay, last question in here.
I think the most important step to do is to bring it out of illegal conditions. I mean, as you maybe know, there is a lot of illegal therapy. And the problem with the illegal is you must hide it, and the therapists who do it, they have to hide it. They are not in communication with others. I think when we can do this therapy on a legal basis, we can talk to each other, and we can say it is important that we do supervising, that we do intervention teams, and when you are talking these problems, I think that's the most important part of it. That not everyone does it in a hidden place, and people are admiring the guru or whatever, and nobody knows outside. That's the most that makes the problem. I think that is so secret. And we make it open. I mean, that's not 100% solution, but being in networks of therapists who discuss these problems, I think really could be of great help. If it's necessary to make it on a higher level, yeah, maybe I would say it's enough when you are an honest psychotherapist who is ready to get feedback from others. That's, in a way, it's enough, I would say.
But how would you know then? Like, how would you evaluate?
Absolutely. And I mean, there are other methods where narcissistic problematics is always a problem in psychotherapy. And this is not the only field, but I think here it's more prominent. And of course, we will have people who have maybe a problem with that. There is no 100% way, but I mean, we can try to be honest with each other and say, hey, pay attention, and you are not superhuman although you are playing the best music I know or whatever. And hopefully it helps, but there's not a guarantee. Okay?
Okay, we are moving on to the online part. We have quite a few questions to you, Peter. If you don't mind, I'll skip the first one concerning the exclusion criteria because Peter has answered it already. This is the question that also received a lot of upvotes. And yeah, I can fully endorse it. It has been shown that positive expectations about treatment outcome double effect sizes of responses to SSRIs in patients with affective disorders. There was actually a recent paper published this year showing that in the social anxiety disorder. So what would be your prediction about effect size, about effects of psychedelic assisted sessions? So I guess, how much do you think the expectations about the positive outcome would influence the outcome of a psychedelic assisted session?
Yes, I think that is a bias that exists because who will participate in an LSD study? Someone who is interested in participating in an LSD study. And he has expectation. Otherwise, you have randomly to take people. But I would not do LSD therapy with people who are not motivated to do it. So I think this question, I understand it. It's true. But nevertheless, I would not do it in another way.
Right.
Yeah.
Thanks. Next question. What's your opinion about working with relatives in a psychedelic-assisted therapeutic setting?
Yes, that's a good and important question. They are highly welcome, and especially at the end of the session, if there are relatives, to enter the room and to have, we do eating together, and that is a good moment to share with relatives, and I want to enter there and just to bring a kind of reality back into the room, so they are highly welcome. Maybe they should not stay over the whole day long because that would too much influence the process, but at the end or for talks, of course, could be of help.
Thank you very much. I think we have to finish the session, unfortunately, because we are running a bit late. Thanks a lot, everyone, for coming.
Thank you, everyone, and yes.
Okay.
I'd also like to add, if you're interested in more info on upcoming lectures and next year's conference, there's a list here to sign. And if you're interested also in becoming a member of the network, another list here. You're very welcome. And thank you, Peter.
You're welcome.